now it's my privilege to invite Dr. Sri Ganesh, who is the chief instructor of this course and a dear friend. And this is a fantastic course, and that can be made out by the big attendance we have for this course as well today. So Dr. Sri Ganesh, who's the chairman of the Netradhama group of eye hospitals in Bangalore, he's going to be speaking on mastering toric IOL implantations. He's gone on to become, I think, the secretary of the Intraocular Implant Club this year. And among lots of other achievements and innovations, Sri Ganesh is a prolific surgeon and a dear friend.
Thank you. Thank you, Gaurav. And good afternoon, dear friends. So to start off with, when we look at toric IOLs, the number of toric IOLs being implanted is growing, and in our practice, nearly 50% of patients require a toric implantation. The reason is, if you want to get a good result, you need to have a residual astigmatism of less than half a diopter. Otherwise, the patients are unhappy because the quality of vision deteriorates. Now, if you're looking at refractive cataract surgery, either for monofocals or multifocals, it's more critical for the premium IOLs like multifocals and EDOFs that you correct the astigmatism. And clinically significant astigmatism is astigmatism more than 3/4 of a diopter. So you need to aim for getting the post-op astigmatism within half a diopter. So let's look at some of the main points for a toric IOL implantation. One is the biometric formula, which has been covered in detail by Shreyas Ramurthy and Gaurav Luthra. Then you have marking of the axis, implantation and alignment. Then implantation in challenging cases like small pupils, because again the toric marks are in the periphery and then it's difficult to align the lens. Then the last is the rotational stability. If you look at biometric formula, so for torics, when the first torics came in, we had a lot of refractive surprises because we didn't know anything about postercorneal astigmatism. We didn't take that into consideration. Doc Koch was the first to describe this postercorneal astigmatism and how it affects outcomes, and he came up with a Baylor nomogram where actually you undercorrect with the rule astigmatism and overcorrect against the rule astigmatism, and that was a kind of a guideline that gave better results. And now you have the Barrett TK toric formula, and that's what we use with the IOL master, which gives you both the anterior curvature and the posterior curvature. It takes into consideration the PCA. Now, most online formulas for toric lenses also take into consideration the PCA, and this is something that you have to use when you are doing your biometry for a toric IOL. Marking of the axis is very important, but because if you don't have your toric IOL on axis, then you will have residual astigmatism. If you're off axis by 10 degrees, then you lose almost about 30% of the toric power. If you're off by 30%, then you lose all effect. And then if it goes beyond 30%, then you can actually increase the astigmatism. So it's very important to place the lens on axis. You will have to know how to mark the 0-180 degree pre-op with the patient sitting up, and then because to compensate for the static cyclotorsion that happens when the patient goes from sitting to lying down. And then again mark the placement of the axis and place it correctly. Nowadays you have markerless systems like the Callisto from Zeiss, the Varion from Alcon, and if you're using a femto, then the Flax platforms like the LensAR has the IntelliAxis where you get nubs on the capsulotomy, so it's very easy to place it intra-op, like in this diagram here. You get nubs on the, and even post-op you can actually see whether the lens is aligned. Okay, so this is again technique of implantation. Now I like to implant the lenses under BSS, because if you have viscoelastic and you don't remove the viscoelastic completely, if you have visco under the lens, what happens? The IOP goes up, and especially in myopic eyes with large bags, the whole eye is compliant. It expands when the pressure goes up. The bag can open up, and then there's a higher risk of rotation of the lens. There's also a paper by Abhay Vaswada which said that eyes with longer axial lengths have higher rotation of toric IOLs. So I like to implant under BSS, and I like to leave the eye a little soft at the end of the surgery. Don't over pressurize the eye, because then it can rotate, and most rotations happen in about the first 6 hours after implantation, and don't ask the patient to lie down for some time, not immediately walk around. Let's place this video. So yeah, so I just fill the chamber with BSS. You can also have an irrigating cannula. I don't use an irrigating cannula. I just form the chamber with BSS, and this is actually a screw type lens. So both screw type and shooters, you can use this technique. And I just nudge the lens into the bag, and you can see that it's on axis with the Callisto. That's the Callisto system, and that actually helps you reduce your surgical time, putting in viscoelastic, removing viscoelastic, leave it a little soft at the end of surgery so that the lens does not rotate. You have to wait for the lenses to open, because many of the hydrophobic lenses take a very long time to open. So if you're impatient and you shift the patient before the lens has opened up, then the contact with the bag and the fornix is not adequate, and these lenses will rotate. Today, lenses have textured haptics or rough haptics so that you have a better contact and lesser incidence of rotation. So select a lens with such a haptic so that you have lesser incidence of rotation. So we also did a study to evaluate the rotational stability. We had 2 groups, one implantation under BSS, one with the viscosurgical device, and 100 eyes of 100 patients, 50 in each group, and we followed them up for a year. And this is what we found, that the rotation was much lesser. This is the amount of rotation, 0 to 5, 5 to 10 degrees, and more than 10 degrees. And you can see that the rotation was much lower in the BSS group. What happens to small pupils? So I've made a marker known as the GANESH Toric marker, because you can't see the peripheral marks if the pupil comes down. So this is available from Epsilon. You can just, it has a blunt edge and 2 windows. You can kind of look at the toric marks through the windows and then press down on the lens. When you press down on the lens and hold it for about 30 seconds, it kind of leaves an indentation and a mark on the center, which is temporary. This is not a sharp edge, it's a blunt edge. And then you can see that you see that mark very clearly. You load the lens in. So sometimes after flax or even intraoperatively, the pupil constricts. So by the time you have finished your phaco, you have a pupil that is constricted, and then you can't see the lens placement correctly. This is not a very small pupil, because I want to show you the peripheral marks also and how the alignment happens. This is injected into the capsular bag, and I'm using the Callisto system, so you can actually rotate. Though you can't see the peripheral marks very clearly, you can align the central indentation and the mark very clearly. This is a temporary mark. It disappears in about 5 minutes. And next day, we have even done tests. We have looked at the quality of the surface. We have looked at scatter. There's no difference from a regular lens. So by the time you finish your surgery, it's almost disappeared, the indentation. But you can make sure that it's aligned at the end of the surgery. And we also did the eye trace. This is the eye trace of that patient. You can see that it's perfectly on axis. Coming to rotational stability, again, you have capsulotomy fixated lenses like the Femtis, and this is my own design of the swivel haptic IOL. We're going to start multicentric trials for this, and then we hope to commercialize it in a couple of years. So with capsulotomy fixated lenses, you place the lens into the capsular bag. You have the swivel haptics, which you can swivel over the anterior capsule. So it captures the capsulotomy. Even with the Femtis, you have flanges which capture the capsulotomy. So the advantage is there's absolutely no rotation. With my lens, you can even go under the IOL and then remove the viscoelastic, and it's perfectly on axis. The lens does not move in the post-op period. You can see this is the result at 2 weeks. So that's few of the pointers for toric IOL implantation. And I would like to invite you for the 37th APA-CRS, which is again an international meeting, which is going to happen in August in Ahmedabad. Thank you very much for your attention.